So clinicians have gone from being very patient-facing to being very computer-facing. They're talking to a patient, they're sort of observing the patient, but they're spending a lot of time entering data into digital systems. And that isn't necessarily the best use of their time. They go to medical school for a very long period of time and go through extensive training to work with patients, to treat patients, not to be data entry robots.
Hello, I'm Dr. Amit Shetty. Welcome to the Future Health Podcast. This is the podcast about the way we work, the work we do, and how technology will influence the future of work in New South Wales Health and the healthcare industry as a whole. Our guest today is Lachlan Rudd from eHealth, a leading data expert who will discuss some of the vast technology improvements that support New South Wales Health to deliver care to every citizen in New South Wales. And I'm looking forward to digging deeper into the future of work with him. What is eHealth and the world of AI, wearables, IoT, and the many other fascinating possibilities all about? Well, we're about to find out more. With me now I have Lachlan Rudd, the Director of Data and Analytics at eHealth New South Wales. I'll let you introduce yourself and give a bit of your background and how you got into New South Wales Health, and then we'll take it from there.
Oh, sure. I've got a varied career background. Got my start in finance, was working in China during the GFC on international mining and infrastructure investment. Retrained as a mathematician about 5 years into that. Worked at CSIRO for a number of years. Had a stint in the private sector developing big data analytics products, and then took that skill set here to New South Wales Health, working with large, clinical and corporate data sets and looking at opportunities to derive value from that data.
What things have you done in health to date, and where do you see this going into the future?
Well, there's an exciting project about sepsis that I am currently working on.
We've done sepsis with Mick.
Oh, yeah, sure.
Okay, yeah.
Yeah, so a different interesting one is around how we derive value from our operational data sets in the clinical space. So another project that we're working on is in the ICU analytics. So we have huge volumes of people going through our ICUs within New South Wales, and there are clinical processes about the best model of care for taking care of those patients. But those processes were designed in randomized controlled clinical trials decades ago in some instances in foreign jurisdictions, Canada, America, Europe, etc. They don't necessarily align perfectly with the people here in New South Wales. And they also talk about populations of people. They talk about, this type, broad group of people should be treated in this way. But in reality, you as an individual can be quite unique in the way that treatment is best directed towards you. So what we're trying to do in this particular use case is move away from these bigger population health type analyses and population health decisions about how an individual should be treated, and seeing if we can take the wealth of data that's now available within our digital systems and really come up with treatment pathways that are best for the individual. So that first step down, personalization of medicine or precision medicine without going down the full genomics route. You can get a lot of the you can get some of the way to that true genomics use case by just the phenotype, the way that the genes express themselves. So what you can observe in an electronic medical record can really help guide how best to treat you as an individual person. When you think about the average patient who arrives in a hospital, and that's really who these treatments are designed for historically, is the average patient, that average patient has one ovary and one testicle and doesn't really represent the normal person that you would think of when a person in the public thinks average patient.
Yeah, no, that's very interesting. So what have been your key challenges whilst you realize that these things are what you need to be developing in? And we'll get to how it'll look in the future, but as you go along, what are the key things you're finding?
Yeah, so health systems in Australia have great access to administrative data sets. So there's been a long history of getting access to high quality data assets about the outcomes and activities that occur within the health system. But what's traditionally missing from these large curated data assets is all of the steps that lead to those outcomes. Now, those steps are in New South Wales captured within our digital systems, but they're captured in there for clinical use cases where you only really need to surface one patient record at a time. There hasn't really been that need to get get the big data view of everything that's happening concurrently and applying advanced analytics over the top of it. So one of the challenges that we're running into is with the mix of ICT systems that we have, how do you sensibly pull that huge volume of data out and make it available for these types of analyses to really return value from that data to patients to lead to better outcomes for those patients in New South Wales?
It's almost like creating digital sensors for the patient's journey, you think?
Yeah, I mean, that's one way of looking at it.
We'll just take a slightly different tack from it. So how do you see that individual patient's journey changing in the future?
Yeah, so that's an interesting one. I think the biggest change that we're going to see over the next 10 to 20 years in the automation sense is a move away from what we have seen in recent years with the introduction of digital systems. So clinicians have gone from being very patient-facing to being very computer-facing. They're talking to a patient, they're sort of observing the patient, but they're spending a lot of time entering data into digital systems. And that isn't necessarily the best use of their time. They go to medical school for a very long period of time and go through extensive training to work with patients, to treat patients, not to be data entry robots. I think the biggest advantages for computerization and automation in health is going to be how we automate that collection of data, how we start getting sensors in beds, in diagnostic machines, so people aren't manually taking readings from screens and transcribing them, how we get cameras around the hospital observing what's occurring and taking those observations and actually recording structured information from those observations that help medical professionals make better decisions faster, instead of them having to pass through 10, 20 years of patient history, which could take an hour to read through. How can machines intelligently surface all of the information that's relevant for the decisions that need to be made then to that clinician, so they can rapidly digest that and then engage directly with the patient, human to human?
Yeah, no, I totally agree, because we were discussing this before around the need for changing that whole the data journey, for instance. And I think to date, I don't know if you noticed or a lot of focus has been put on data storage and data access, but we need to look at data as the whole journey from the point of origin to the point of dispensation and how it converts to information and the circle back into systems. And you raised that good point around data collection, and the whole reason that human computer interface needs to change. So it's more about data capture rather than data entry. It's a great point you make. I'm just going to turn the tack again a little bit and go back to one of the things I know you've done in the past is around looking at the future of work and future of workforce as well. Is what would your key salient things be around how do you see that changing the workplace and the workforce?
Yeah, so when you're looking at impacts of future workforces, what you can really boil it down to is the skill sets that are required to deliver a particular job. The more that you lean towards either fine motor control, so really nuanced sort of movements, even things like folding a towel that a human may think is simple is actually quite complex in the variables that you have to control for. It's difficult to create a automated sort of manufacturing line that folds towels. Interestingly, if you're using like robotic arms and things like that, it's just a surprising thing in the automation space. But the thing that really makes people vulnerable to computerization and automation in the long run is when they're doing very repetitive tasks in simple, well-defined spaces without much complex reasoning behind them. So you'll find people in, say, the transportation profession, so taxi drivers, truck drivers, that's a fairly routine task where you can see things like the automation of vehicles coming along and potentially displacing huge cohorts of the workforce. But then you run into interesting professions like baristas and hairdressers, where ostensibly we have coffee machines today that you can press a button and make a coffee, but the barista hasn't disappeared. That social element actually makes the profession quite sticky. People don't just go there for the taste of the coffee, although that's a part of it. It's the broader experience and sort of the interaction with these professionals. Likewise, you could have some very scary machine that descends on your hair and chops it to bits in perhaps a compelling way. But again, I think people are going to have more trust in hairdressers to do that job well for a longer period of time than a machine's going to come along. Likewise, people in the medical profession are quite safe from that robots coming to take their jobs, because a key part of delivering quality care is that human-to-human interaction. You can't really replace that with a robot in any way that makes people feel at ease. At least that hasn't been proven as yet.
And it also raises the whole issue around replacement versus change and ensuring that the change is in the positive direction. So what's left for the human to do is a more meaningful task rather than, and like you highlighted in automation, it's those menial tasks that have been automated rather than the high value items of human interaction.
Yeah, there was actually like an interesting study put forward out of Oxford University where they built this machine learning model effectively on top of broad skills data sets from the US, which mapped which skills are required for every profession, then to changes in those occupations around the world. And they tried to work out, okay, based off of history, what is most likely to be sort of automated next, which skill sets and which jobs are going to be on the chopping block. And what they had at like number 2 or number 3 was fashion models, as catwalk models, because the machine learning algorithm coming in there naively assumed that all you do is drape fabric on a person and they just run backwards and forwards down a catwalk. You can easily get a robot to do that, just to like zip it down, it's all good. But again, like it's...
It'll have to be a very good looking robot, I suppose. That's very interesting. And it's interesting you highlight that data set because we've recently used that to build industry risk models from COVID.
Yeah.
And we've done that in New South Wales as well. So it's very interesting that our team has done a piece of work around what are the aspects of your work which put you in risk for COVID and what environments they are in. So it's really interesting piece of story you shared there.
Yeah.
You were about to...
The one thing that you can't capture though, right, that you can't predict in terms of the future is disruption, because that's always unexpected. What I was talking about previously is observing the past and what led to past changes in the workforce and assuming that it's going to continue into the future. But that doesn't account for those big changes that
like
no one can
now.
predict. Like one of the famous ones that's always sort of brought out is, I think it was back in the early 1900s perhaps, they were predicting that New York City would be buried under 10, 20 meters of horse manure at the rate that horse-drawn carts were sort of increasing within the city. But then of course, the motor vehicle comes along and replaces that. And we don't know what the next motor vehicle in healthcare is going to be. Is there going to be like one pill that just makes everyone, live forever? Probably not in our lifetime, but like those kinds of disruptions are impossible to predict.
Yeah, you also highlight, in your job, you probably are seeing a lot of cutting edge things already happening through analytics and a lot of these new algorithms. And a lot of these algorithms will definitely change the way we deliver care. What are the key challenges you see of these new technologies, many of them unvalidated?
Yeah.
Whether they do improve care is yet to be proven.
Yeah.
And how that can be done safely in future patient environments.
Yeah, I mean, the ethics around that safe argument are impossible to solve, and there are similar problems in the delivery of self-driving vehicles that are happening today. Like one obvious example is you could have a clinical process that exists today that is effective for 80% of people. And you develop some new whiz-bang piece of artificial intelligence that improves that process, and now it's successful for 90% of people. But of that 10% it doesn't work for in the AI use case, that's 10% that it previously worked for under the old use case. So ethically, how do you improve things for everyone if you're going to make things worse for a smaller group of people? And if previously it was more of a rule of thumb, loose guideline that was followed by humans with a lot of messiness and not much accountability behind it, where it wasn't really scrutinized, when you move to the AI world, everything becomes measurable. So you know exactly which patients you didn't help. And once you know those figures, how do you act about that? Like how do you implement something that you know is going to cause harm, and you know where it will cause harm, but it will cause less harm than the previous thing? And how do you do that ethically?
Yeah, and I think the whole challenge around automation and augmentation is one of those discussions to have, is that, in one of the sepsis algorithms we're putting in, we're still allowing the clinicians to do the clinician gestalt and add people who they would have previously added to the pathways.
Yeah.
And then having AI to just support picking up people they were likely to miss.
Yeah, this is a huge one too. So I think it's incredibly risky for AI to ever replace clinical decision making, probably within our lifetime, until you get to the point where machines can observe everything that a clinician can observe and interpret those observations to the same level of clarity. There's no way that AI can replace a clinician. But where the real value is in that augmentation piece. So clinicians aren't data entry robots. They don't have an infinite amount of time to review all of the historic information on patients. There's huge scope for artificial intelligence to help take the wealth of information we're now collecting in digital systems, condense it down into bite-sized chunks, present it to clinicians when and where they need it to help them make better decisions and allow them to spend more time with the patient and less time with the machines.
Yeah. How do you see all this changing the design of hospitals in general?
Yeah, so that's an interesting one. So I imagine that there would be streamlining of just design of clinical processes around machines doing the heavy lifting. A lot of the double checks and redundancy that would exist in clinical practice today could be covered by simple mechanical mechanisms in the future that, would really change the way that a patient flows throughout the hospital. I guess too, with the advent in technology, things are going to get smaller and there won't necessarily need to be dedicated spaces for dedicated procedures. So you'll have a lot more flexible to reconfigure parts of the hospital on an as-needs basis without anywhere near as much downtime as you'd experience today, which leads to certain components of the hospital being designed just for specific activities. The other big change too is we probably don't want everyone going to hospital in the future. With the advent of these new technologies, hospital in the home and virtual healthcare becomes more and more prevalent. I imagine people would far prefer to be recovering at home where they're much less likely to catch some horrifically deadly disease from another patient in hospital if they can avoid it. Hospital is really your last port of call when it's absolutely required.
Yeah, there's definitely benefits and disadvantages of cohorting people with illness.
Yeah.
That's true. We've talked a bit about this around augmentation and automation. How do you see this playing out in the role of the clinician or the workforce in the hospital?
Yeah, so there's this interesting view that as we collect more data, it's going to become more useful for more people. But that's not the case if the data isn't well understood and is weird and wild and varied across the system. I think one of the biggest changes that's going to happen at the clinical coalface of this sort of digital revolution is a reflection on what standard care looks like within New South Wales. If you really want to behave as a system and derive value at scale, you need to behave in consistent ways for the machine's recommendations or the assistance that the machines and automation are trying to give to actually mean the same thing across sites. So if one clinical team in one location behaves in a certain way and a different team behaves in a different way, and then you've got an algorithm in the middle of those two teams who's assuming that all the information means the same thing, that's not actually the case. So you may run into a situation where a person is being treated and that treatment may be based off something simple like their temperature. Perhaps at one site, a treatment is given and then a temperature is read and that temperature is put into the system and that's after the treatment. And then at another site, the temperature is taken, put into the system and then the treatment is given. And all the machine sees is temperature there, and it doesn't really know what that means. It doesn't know the context around why that temperature was recorded. So when it gives a prediction or a clinical decision support type nudge towards a clinician, it's probably going to be wrong if it's misinterpreted what that data fundamentally means. So to really drive value from our data across the state in its entirety, I think we really need to begin from a people and process standpoint, agreeing what best practice looks like for the system, agreeing on consistent operating models across the state, and building our digital systems to enable those operating models. Not the other way around, where we seem to sort of have a lot of variety across the system. We have a loose idea about what a good model would be, and we build our digital systems around it, but we don't have that change management in place to really disperse that model across the system.
I agree with you, and I think that has been one of the cases with tailoring our processes to the EMR rather than the other way around.
Yeah.
Where I know the teachings of medicine have always been around a stepwise approach to things, and I think those processes are not different. But they also highlight that point around how you raised before around clinical trials information from international patient data sets suddenly being imported and then dropped into New South Wales. And there is almost a value on having that almost flexibility in building algorithms locally and then being able to run it on the fly and redesign them based on local populations as well. And use cases as well. But they're not discounting the need for a true data dictionary and definitions defined through right processes. And I think that's a key point there.
Yeah, just having digital systems doesn't make the data usable. It's very easy to overwhelm the system with the volume of data that we're generating. We need to really focus on how we curate that data and ensure that it's actually available to drive value and return that value back to patients within New South Wales Health with better clinical outcomes, and clinicians hopefully spending less time working with machines and more time improving patient outcomes.
Yeah. Now, look, that's how much time we've got for today. I'm sure there's so much more we could talk about. Thanks for coming along, Lachlan, and it'll be great to catch up with you again soon. Thanks.
Thanks.
So that's all we have time for this episode. Thanks for joining me on the show. If you enjoyed the podcast, make sure to like, share, and subscribe on whatever platform you are on right now.